Patrik Hutzel here from intensivecarehotline.com with a live stream today where I want to answer your questions if you have a loved one in intensive care. And today's live stream is about how long does it take to wake up after an induced coma. So that is one of the most commonly asked questions for families in intensive care, and it's a question that we get all the time. So first off, I want to encourage you to call into the show if you like, and you can call me on 415-915-0090 if you're in the United States or in Canada. That is again 415-915-0090 if you're in the United States or Canada. If you're in the UK, you can call me on 0118-324-3018. That is again 0118-324-3018 for UK callers. And if you're in Australia, call me on 041-094-2230, and you can call live into the show. So many families in intensive care, when they have a loved one in there, a majority of patients in intensive care end up on a ventilator with a tracheostomy. Sorry, I have to correct myself here. A lot of patients end up in intensive care on a ventilator with a breathing tube / endotracheal tube. When someone ends up in intensive care with a ventilator and an endotracheal tube or a breathing tube in their mouth, they need to be induced into a coma. Simple reason for that is that this very breathing tube or endotracheal tube is so uncomfortable that it can't be tolerated. Mechanical ventilation plus the breathing tube is very uncomfortable. It's obviously needed for intensive care treatment. If patients have a pneumonia, patients come into ICU post-surgery when they were in the operating room, in the operating theater, and had anesthetics for surgery, they can't be woken up without a ventilator straight off. So that's the background there. Unfortunately, in intensive care, some patients end up on a ventilator for longer than others. In the ideal scenario, you ventilate someone, for less than 24, 48 hours. Short term, you wean off sedation. Hopefully a patient is neurologically intact, and then can be extubated. From there, extubation is the removal of the breathing tube. So that's the background there. If someone can't be extubated quickly and they end up on sedatives as well as opiates, then chances of a delay in waking up are definitely there. The longer someone is in an induced coma, the higher chances that there are delays when waking up. And that's when all the questions are asked, why is my loved one, why is my mom, my dad, my brother, my sister, my spouse, why are they not waking up after an induced coma? So that's the sort of background there. And then it also depends, obviously, how severe is the critical illness. For example, is ventilation and a breathing tube temporary for, let's just say open heart surgery? If open heart surgery such as bypass grafts, coronary artery bypass grafts, or valve repairs, valve replacement, if it's straightforward, then, someone should be extubated after 24 to 48 hours at the most, sometimes even after 12 hours if all goes well. If someone is in an induced coma in a breathing tube and things are not straightforward, such as maybe a severe pneumonia, such as ARDS, lung failure, such as multiple trauma, such as a head injury, Guillain-Barré syndrome, the list is endless. I would say that anything that's above 72 hours, 96 hours, 3-4 days, and if you're trying to wake somebody up then it's often not a straightforward process, and it can take some time. Now, it also often depends on what sedatives are used. Let's just quickly break this down so you understand this. The majority of sedatives that are used in intensive care for an induced coma are Propofol, also known as Diprivan. It's a white substance that's given intravenously. Propofol or Diprivan made highlights many years ago when Michael Jackson died, because apparently Michael Jackson's doctor prescribed him Propofol for home use, which is unheard of. If someone needs Propofol, it needs to be in a monitored and safe healthcare environment such as ICU, emergency room, theaters, and that's where Propofol can be given safely, because you can't really give Propofol without intubation or without ventilating someone, because people stop breathing and it can ultimately lead to death, which is what happened in Michael Jackson's case. Propofol is also known as short-acting, which means it has a very quick onset. It sedates people very quickly. It puts them to sleep very quickly. And when you stop it, it also stops working fairly quickly. And, if all goes well, people should wake up within minutes, really. Main side effects of Propofol are hypotension, which is also known as low blood pressure. And many patients in intensive care, you got to be very careful how much Propofol you're giving, and if you're giving a bolus, because it can cause the blood pressure to go down. Now, the advantages of Propofol are simply, again, that it's short-acting, and if you want to sedate someone and ventilate someone for a few days, and given that it's short-acting, the chances of someone waking up after giving Propofol, is higher than with any other medications, and I'll come to that in a minute. So when someone is having or is induced into a coma, they often also end up with opiates. Opiates are strong pain medications such as morphine, fentanyl, remifentanil, hydromorph. Those are the most common opiates in ICU being used when someone is induced into a coma. And again, the reasons for that is that the breathing tube or endotracheal tube in the throat is very uncomfortable. Patients are often in pain anyway after surgery or after trauma, head injury, or any other critical illness. It often goes hand in hand with pain, unfortunately. So therefore, you need to give strong opiates as well. Now, the opiates come with very undesired side effects, which is such as addiction, especially when it comes to prolonged use of morphine or fentanyl. Other undesired side effects are respiratory depression. Now, think about this. You have someone on a ventilator with a breathing tube or an endotracheal tube, and the ultimate goal is to wean them off the ventilator. And now you're having to give opiates such as morphine or fentanyl, and they have as the side effect respiratory depression. Now that is a real concern, because you want to get someone off the ventilator as quickly as possible, and yet they are getting a drug that has respiratory depression as a side effect. So that is a real concern, and unlike Propofol, morphine or fentanyl are often not short acting, and they stay in the system for a little bit longer. Some patients in intensive care go into kidney failure or go into liver failure, and then it takes even longer for morphine or fentanyl to be metabolized, and again, potentially delaying the waking up process. It's also important to notice that waking up in intensive care is often a process and not an event, especially when there are complications, especially when someone has been in a prolonged induced coma. And I would argue that anything above 3 or 4 days in an induced coma, I would consider as a prolonged induced coma. Let's just say someone is in an induced coma and it needs to be more long-term for whatever reason. Maybe patients are awaiting surgery, maybe patients are in situations such as ARDS, which is very common at the moment with the COVID pandemic still going on. And then Propofol may not necessarily be the first drug of choice anymore. The drug of choice for a prolonged induced coma might actually be midazolam, also known as Versed or Dormicum. And Versed or midazolam is a benzodiazepine, and it's more on the long-term acting drug classification. And whilst it has a quick onset as well, just like Propofol, it stays in the system much longer, and it takes a lot longer for patients to wake up. Now, it doesn't have the side effect such as hypotension or low blood pressure like the Propofol has, but the other effect that it has is it is addictive as well, especially when it's being used over long periods of time. So just from what I mentioned before, you have the combination of Propofol and morphine or fentanyl, and then you're having midazolam in combination with morphine or fentanyl. Now, whether you're using midazolam and morphine or whether you're using midazolam and fentanyl, both are highly addictive. And when someone wakes up from an induced coma, or is trying to wake up from an induced coma with those highly addictive substances, they may go through a withdrawal from those substances first before they can actually wake up and before you can assess their neurology properly. Why is assessing someone's neurology so important? So when someone comes off the ventilator, was trying to come off the ventilator, is trying to come out of an induced coma, you got to make sure they're neurologically intact. They can obey commands, they can move all limbs, they can poke out their tongue, they can cough, try do all the right things. Why is this important? Well, it is important. Not only have you got to talk them through the breathing process, they got to be trained to breathe by themselves. They got to be shown how to cough again, maybe. And you got to make sure that all senses are there, because once you take the breathing tube out and they can't maintain their airway because they're neurologically not intact, you're having a big problem, because you got to put them back on the ventilator again. So your time window to take someone off the ventilator and to get them out of the induced coma, to take the next steps towards getting them off the ventilator, is time sensitive. And you got to choose the right time. So when you take the ventilator out or the breathing tube out, that people can continue without needing the breathing tube or endotracheal tube back in. So what you've also, and what a lot of people have also reported, and I have obviously seen it, probably hundreds of times when I was at the bedside in intensive care as a critical care nurse. When someone does wake up, they're often getting very agitated. They're often breathing against the ventilator. They're often coughing. They're very irritated. And then one might think, oh, they're awake. Why can't you just take the ventilator out? Well, the problem there is that if you did that and they're not following commands, there's a very good chance they can't maintain a safe airway and they're not cooperative. Unfortunately, you need patients to be cooperative, and only then is it safe to take out the ventilator. Now, if a situation like that occurs, some families report they're not trying long enough, they're not trying hard enough. And I probably agree with that you can't just take sedation off for a minute or two and then, someone breathes against the ventilator, is coughing, seems very agitated, potentially aggressive, and then you put the sedation back on again. I totally agree with that you need to give this some time. From experience, I would say at least 30-40 minutes, and that's a challenging period, especially if someone is not cooperative. You need to, possibly have a second nurse there, and you need to talk to people, you need to talk to your patient, you need to calm them down if you can. Problem is, when they're waking up, it's very hard to assess what's going on in their head. They often have no recollection of why they're in ICU. They have no recollection of what's happened. They're waking up, they've got a tube in their throat, and they can't make sense out of the situation. They can't talk. It's a horrible situation, actually, if you think about it. And, they're in ICU because they're critically ill. And therefore, they may need the ventilator for longer than anticipated. In any case, it is definitely something that, many families have seen, right? They have seen that, and they're wondering why is my loved one not waking up? Again, all those medications they're getting, whether it's Propofol, morphine, fentanyl, midazolam / Versed, again, they all have side effects such as hallucinations, and when people are waking up, it's not straightforward. Those drugs are also known that if given off over a long period of time, they're also known to induce ICU psychosis, ICU delirium. Now, I'm not suggesting that someone who's been in ICU for 3 or 4 days ends up with ICU delirium or ICU psychosis. There's enough research out there that suggests that the longer someone is in a drug-induced coma, the higher the chances they end up with issues such as ICU delirium or ICU psychosis. Just coming back to what I described here, that if someone is, coming out of an induced coma, but is not waking up appropriately, is not cooperative, is breathing against the ventilator, is potentially aggressive, and so forth. Another reason that might happen is simply that they might have a neurological event happening. So what do I mean by that? When someone is waking up after, let's just say, head injuries or brain injuries, you're almost expecting that waking up is not straightforward. But when someone without neurological deficits or without a neurological pre-medical history is not waking up appropriately and can't follow instructions, can't move all limbs, can't poke out their tongue, can't squeeze hands, can't wiggle their toes, whatever you ask them, then chances are they might have had a neurological event, such as a stroke. Right, and then the next step is that after maybe a few failed attempts of waking up and ongoing neurological deficits, the next step is to rule out a neurological event such as a stroke, or maybe also another neurological event is such as seizures. How do you do that? Well, next step usually is to do a CT of the brain and find out, whether stroke might have taken place. You should definitely make a neurologist or a neurology referral. Let's let the experts look at that. So that would be another concern, obviously, and it is something that needs to be addressed. The bottom line is this. I can't stress enough that waking up after an induced coma is a process and not an event. And therefore, this can take time. And there are no firm timelines around this. Now, I can understand your frustration completely, because the longer it takes for your loved one to wake up, the more negative the ICU team will be, and the more doomy and gloomy they will be. And they're giving you all these negative and doom and gloom scenarios that, you don't really want to hear about. And at the end of the day, it is, even if someone is not waking up for a week in ICU after an induced coma, it's still not a long time. I can't stress this enough, that, a week in ICU, even 2 weeks, is not a long time. And things like that simply take time. So then the question is, how long is too long? I've seen patients that, all sedation has been off, and then they're not waking up, for a few days, and you've ruled out a stroke, you've done a CT of the brain, there's no stroke, and they're still not doing anything. So that's when it really becomes tricky. But then again, you got to be patient in those situations. Problem is that the longer someone does stay in an induced coma, the more deconditioned they get, the more time it takes for them to recover. You got to do the physiotherapy, the physical therapy. You got to get them mobilized. There's definitely undesired side effects that come from not waking up after an induced coma in a time frame that seems appropriate. But again, the other issue that I believe is happening there, not only are patients being weaned off the sedatives and the opiates, they also had a critical illness. And when someone is critically ill, the body more or less shuts down and simply needs time to recover, even without sedation and an induced coma. People are not machines, and they just need time to recover. They just need to take time for themselves to let their body recover in their own time. And I believe that's always a big issue as well, that it simply takes time to wake up. So if, God forbid, someone doesn't wake up and therefore also can't come off the ventilator, the next step in this situation is to do a tracheostomy. But even before you do a tracheostomy, if you think for whatever reason, maybe a patient had too many opiates, too much fentanyl, too much morphine, or also too much midazolam in particular, not so much the propofol, because propofol, the body can metabolize pretty quickly, but all the other medications, morphine, fentanyl, midazolam / Versed, the body can take much longer to metabolize. And then sometimes you may also have to consider whether an antidote needs to be given, such as Narcan for morphine in particular. That reverses the effect of morphine. The same is happening for midazolam. If midazolam, or if you think a patient had too much midazolam, another medication or antidote medication that you can give for midazolam is, I believe it's flumazenil. I just quickly need to type it into Google. I can't remember exactly, but I think that's what the medication is called. It's flumazenil. To reverse some of the actions of the midazolam in particular. Other things that can happen when someone is not waking up after an induced coma, or they're confused, they're not working with you, they're not cooperative and so forth, is simply, you have to consider whether they're going through withdrawal. They're going through withdrawal from the midazolam / Versed, they're going through the withdrawal from the morphine / fentanyl. Or if for whatever reason they are, they have been drinking heavily before the ICU admission, or they have been drug users, they might be withdrawing from alcohol, they might be withdrawing from drugs. And then that's when you need to consider, okay, what are your next steps? How are you dealing with potentially a withdrawal situation? And if you are dealing with a withdrawal situation, you might have to consider medications such as clonidine, or also Precedex, also known as dexmedetomidine, that can help with a withdrawal from medication or substances situation. So those are the things that are important. One other thing that is important when someone is not waking up after an induced coma is sitting them up. That's the bare minimum someone needs to do. You got to sit them up in the bed. That's the bare minimum. Ideally, you can sit them in a chair. You can get them in a tilt chair, maybe even in a recliner. I know most ICUs will dispute that for some of our health professionals that are watching this, but I have worked in ICU where we have mobilized patients as quickly as possible, even with breathing tubes. Is it more risky that the breathing tube will come out? Absolutely yes, but it can be managed safely. and it'll just stimulate patients, and it's easier for them to wake up. It's easier for patients to get familiar with their surroundings. There's touch going on, nurses are touching them when they're getting mobilized. It's just more stimulation. Other things that need to happen when someone is waking up after an induced coma is simply physical therapy or physiotherapy, arm movement, leg movement, breathing exercises, also changing the ventilator settings during physiotherapy is important. And again, it helps stimulate patients. I do want to leave it there today. It's just a quick refresher. We have done many other videos and podcasts around how long does it take to wake up after an induced coma. It's just a quick refresher. Not much has changed from my perspective. I think if anything has changed, I want to leave you with that, is especially for those of you that have family members in ICU with COVID and ARDS. I think if anything, patients during the COVID pandemic have unfortunately been kept in an induced coma for much longer, because the option of a tracheostomy has often been delayed, especially for COVID patients, because the risk for intensive care health professionals to contract COVID has been very high because of aerosols going into the atmosphere when doing a tracheostomy. Therefore, induced comas have been prolonged, and the side effects of and the undesired side effects of an induced coma have come more and more to the forefront, which is even often a bigger delay in waking up after an induced coma. So I hope that helps for today. This was a short summary. Go and like this video. Comment down below what questions that you have, if you have any follow-on questions, and subscribe to my YouTube channel for more of these videos, for quick tip videos, for questions answered. And I'm planning to do more of these live stream videos where people can either type their questions in the chat pad, or where people can also dial into the show and I can answer their questions live. If you have a loved one in intensive care, go and check out intensivecarehotline.com. Send me an email to support@intensivecarehotline.com, where me and my team will get back to you with some answers to your questions. The shortcut really is to call me directly. If you're in the US, call 415-915-0090. That's again, US and Canada, 415-915-0090. If you're in the UK, please dial 0118-324-3018. That is again for our UK viewers and listeners, 0118-324-3018. And for our Australian viewers, please call me on 041-094-2230. That is again for our Australian viewers, 041-094-2230. There's also a section on our website where you can schedule an appointment with me, and then we can go on a phone call or on a Zoom call. And I also have a Skype account that you can see on our website, intensivecarehotline.com. You can also connect with me via Skype. It's a pleasure helping you and your families. This is Patrik Hutzel from intensivecarehotline.com, and I will talk to you in a few days. Take care for now.